Hi everybody, welcome to our module on renal and bladder malignancies. In this module we're going to talk about cancers that occur in the kidney and the bladder. These first three here are kidney cancers, and of these three, renal cell carcinoma is far and away the most common. And then we'll talk about these three, which are bladder cancers, and of these three, transitional cell carcinoma is far and away the most common. The other two are very rare. So we'll start by talking about renal cell carcinoma, which is the most common type of kidney tumor. It is an epithelial tumor that arises from proximal tubule cells. So look down here on this picture of the nephron. This is the proximal tubule right here, and this is where the cells lie that are going to cause cancer in renal cell carcinoma patients. Renal cell carcinoma is more common in men, and it's more common in older people, about 50 to 70. And then very important, cigarette smoking is a risk factor for renal cell carcinoma. Also, obesity is an important risk factor for renal cell carcinoma. So there's a classic triad of symptoms that you should know for renal cell carcinoma, and that's hematuria, a palpable abdominal mass, and flank pain. Now, having said that, less than 10% of patients have this classic triad, but when it is present, it strongly suggests renal cell carcinoma. Many patients with renal cell carcinoma have fever and weight loss, and also many patients are asymptomatic until the disease has advanced. So when people are finally diagnosed with a renal cell cancer, about a quarter have metastases or advanced disease. Renal cell carcinoma commonly invades the renal vein, and this causes some symptoms that it's very high yield for you to know. This can block drainage of the spermatic vein on the left. So recall that the left spermatic vein drains into the left renal vein, and from there goes to the IVC. So if you have blockage of the left renal vein, you can get a left varicocele, and this is a classic finding in patients with renal cell carcinoma. Importantly, you cannot get this on the right because the right spermatic vein drains directly to the IVC. So invasion of the right renal vein will not cause a varicocele, but invasion of the left will. Renal cell carcinoma likes to spread through the venous system, and commonly it deposits in the lung and in bones. It can also spread to retroperitoneal lymph nodes. There are a number of paraneoplastic syndromes that occur in renal cell carcinoma that you should know about. The first one is polycythemia, and this is because the tumor can produce erythropoietin, and this can give the patient a high hematocrit. You can also get hypercalcemia from renal cell carcinoma, and that's because the tumors often produce parathyroid hormone-related peptide, and this will increase the calcium resorption from bones, just like regular parathyroid hormone does. Patients with renal cell carcinoma are often hypertensive, and that's because the tumor produces renin. And patients with a renal cell carcinoma can have Cushing syndrome when the tumor produces ACTH. So what you want to look for to recognize a Cushing syndrome is a patient who has weight gain, hypertension, and hyperglycemia. These are all symptoms of high cortisol levels as a result of the ACTH produced by the tumor. The pathology of renal cell carcinoma is very easy to recognize, and that's because most of these tumors have what's called clear cells. So if you look at this picture down here on the right, you see these cells that are filled with clear material. They actually have glycogen and lipids inside of them, and glycogen and lipids usually do not stain very well, so the cells appear clear. So just remember, it's high yield for your boards to know that clear cell carcinoma is the most common type of renal cell carcinoma. There are some genetics associated with renal cell carcinoma that you should know. These tumors are associated with a gene deletion on chromosome 3, and the gene that's involved is the von Hippel-Lindau gene, or the VHL gene. Many patients get a sporadic mutation of this gene, and this will result in a single tumor, usually in an older patient who's a smoker, as I described those risk factors to you before. But you can have an inherited problem with this gene, and this will give you renal cell carcinoma in a younger patient, usually with multiple bilateral tumors. Von Hippel-Lindau disease is caused when patients have an autosomal dominant inheritance of a von Hippel-Lindau gene inactivation, and they get lots of different tumors. Renal cell carcinomas are just one kind that they get. They also get hemangioblastomas in the cerebellum, and this gives them signs like ataxia, and they can get retinal hemangioblastomas, which give them vision problems as well. The ideal treatment for renal cell carcinoma, if you pick it up early enough, is surgical resection, but oftentimes it's already spread beyond the kidney by the time of diagnosis. You should know that this tumor is poorly responsive to chemo and radiation, and the one treatment that is used is recombinant cytokines, and the one that's often administered is recombinant interleukin-2, which goes by the trade name aldesleukin. And when you give this to patients, they will get very sick. Remember that interleukins are part of the inflammatory response, so this is like injecting the flu into someone's body, so they can get hypotension, fevers, and chills. If you ever get to see patients in an onc ward who are being treated with interleukin-2, you will see that they look like they have a rip-roaring case of the flu, and that's because they're being administered IV cytokines. Next kidney tumor we're going to talk about is the Wilms tumor, and this is the most common renal malignancy of children. It's caused by proliferation of the metanephric blastema, and these are embryonic structures that form the glomeruli, and we talked about these in the module on renal embryology. So the classic case is a young child. The median age of onset is about 3 years old. They'll have a huge palpable flank mass, they'll have hematuria, and then they'll also have hypertension, which is very rare in children, and they will have it from renin secretion by the Wilms tumor. On the left here is a pathology slide of the Wilms tumor, and you can see all these dark purple areas, and that's metanephric blastema tissue which is causing the tumor. Over here on the right is a CAT scan of the Wilms tumor, and you can see that there is an enormous structure inside this child's abdomen. And remember, this is a child, so they're going to be very small and slight, and it's easy to palpate these enormous masses on these children who have Wilms tumor. Wilms tumor is associated with a loss of function mutation of the WT1 tumor suppressor gene, which is found on chromosome 11. This can be a sporadic mutation, but sometimes it's part of a syndrome, and there are a number of syndromes that are associated with Wilms tumor. One of those syndromes is the Wagner syndrome. This is very rare, but patients with the Wagner syndrome develop Wilms tumor. Each of the letters in Wagner stands for a component of the condition. So the W stands for Wilms tumor. The A is for anheridia, and anheridia is absence of the iris. And if you look at this picture over here on the right, you'll see that this person has no irises, just pupils. And in fact, that's one of the ways the Wagner syndrome is often picked up in children, is because it's noticed that they don't have any irises. These children will also have visual problems. Patients with Wagner syndrome get genital anomalies. That's what the G is for. One of the most common things is cryptorchidism, which means the testes don't descend, or ambiguous genitalia. And then finally, these people also have mental retardation. And this is from deletion of that WT1 gene on chromosome 11. Another very rare syndrome associated with the Wilms tumor is the Beckwith-Wiedemann syndrome. So this is a pediatric overgrowth disorder. So these children will have macrosomia. Their height and weight is often greater than the 95th percentile. They have this really strange feature called hemihyperplasia, where muscles in one limb are much bigger than the other. It may look like their arm or leg is bigger than the one on the other side. They have big tongues, that's macroglassia. And they get many embryonal tumors. They get Wilms tumor, but also neuroblastomas and rhabdomyosarcomas. And this is a very rare, uncommon condition. So the last kidney tumor I'll talk about is the renal angiomyolipoma. This is a benign tumor of young children, and it's a tumor of blood vessels, smooth muscle, and fat. And the most important thing for you to know about this tumor is that it occurs in tuberous sclerosis. So tuberous sclerosis is a very rare autosomal dominant condition where patients get cortical tubers in the brain. The word tuber just means a growth or a bulge. And what they get are subependymal hamartomas. So remember, the ependema is the lining of the ventricles and the CSF canal in the brain. So they get subependymal hamartomas, and this gives them problems like seizure and mental retardation. Some other tumors that occur in tuberous sclerosis are cardiac rhabdomyomas, which are also very rare. And an important clinical clue to recognize these patients are that people with tuberous sclerosis have these leaf-like patches of skin with no pigment. They're called ash leaf patches. You can Google and see examples of these, and it just looks like the skin is pale over a portion of their skin, usually in the shape of a leaf. So now we're going to switch gears and talk about bladder cancer, and the most common type of bladder cancer is called transitional cell carcinoma. This is a tumor that's usually found in the bladder, but you can also find it in the renal calyces, the renal pelvis, or the ureters. Basically, anywhere that urine collects and drains in the body, you can find this cancer. You should know that it's often multifocal and recurrent. Patients with transitional cell carcinoma have what's called a field defect, which means there's damage and abnormalities in their entire urothelium. And the urothelium is the layer that lines the collecting system and the bladder. So they can have tumors elsewhere besides just one place where the initial tumor is found. There are some risk factors for transitional cell carcinoma you should know about. One of the most important is smoking. If you hear of a smoker with hematuria, bladder cancer is one of the first things you should worry about. Cyclophosphamide is sometimes given for chemotherapy, and it can lead to this tumor. Phenacetin is an analgesic that's not used anymore. It was banned by the FDA, but it used to be commonly used and could lead to this tumor. Acetaminophen, which is Tylenol that we use now, is a derivative of phenacetin. Aniline dyes used to be used a lot in the hair coloring industry, and for a while there was an outbreak of bladder cancer in women who were hairstylists. And then just remember that anyone who does an industrial job has potential for workplace exposures that often lead to bladder cancer. So rubber, textiles, leather, naphthalene, which is an industrial solvent, these things can all lead to bladder cancer. So in board questions, you want to watch for someone who's a painter, a machinist, or a printer who starts to develop hematuria. Those are all risk factors for transitional cell carcinoma. So the classic case in a patient with bladder cancer is going to be an older white male who is a smoker, and the patient's going to have painless hematuria, and there are going to be no casts in the urine. Remember, casts would suggest a glomerular source of bleeding like glomerulonephritis, but in bladder cancer there won't be any cast. And the test of choice is to do a cystoscopy, which is a camera inserted into the urethra and up into the bladder, and then take a biopsy once you see the tumor. These tumors are treated with a combination of surgical resection, radiation, and chemotherapy. And one thing you should know, especially for step one of the boards, is that the platinum-based regimens tend to be used for transitional cell carcinoma. So drugs like cisplatin and carboplatin are often used in treating this malignancy. So transitional cell carcinoma is far and away the most common bladder cancer, but there are two other types, squamous cell and adenocarcinoma, which are rare, and they occur in some special situations that they like to ask you about on the board. So squamous cell carcinoma is very rare. In order to get this cancer, you need chronic inflammation of the bladder. So what would give you chronic inflammation of the bladder? Well, patients who have had multiple recurrent kidney stones are at risk for a squamous cell carcinoma, or patients who had multiple bouts of cystitis are at risk. And then one special risk factor is if you've ever had a UTI with schistosoma hematobium, which is a flatworm. So let's talk about that a little bit. Schistosoma hematobium is a trematode, and it's found in Africa and the Middle East, especially in Egypt. In parts of Egypt, squamous cell carcinoma is the most common bladder cancer because so many people have been infected with this worm. So you get it from fresh water that contains the larvae, and they penetrate the skin when you're swimming and migrate to your liver where they mature into adults. Very creepy. And then the adult trematodes can infect the bladder, and they usually cause hematuria, but the chronic infection from these trematodes can result in bladder cancer. And this is one way people get squamous cell carcinoma of the bladder, which is otherwise quite rare. So the other rare type of bladder cancer is an adenocarcinoma, and this is glandular proliferation in the bladder, and this occurs in three special circumstances. If you have a urachal remnant, you're at risk for this. So the urachus is what connects the dome of the bladder to the umbilicus in the fetus, and it gets obliterated at birth and becomes the medial umbilical ligament. Some babies are born with a remnant of the urachus, and sometimes it's obvious because they spill urine from their belly button, but other times it's not obvious, and this can lead to adenocarcinoma of the bladder later in life. If you have a long history of cystitis, you can get this bladder cancer just like you can get squamous cell. And then finally, if you have exstrophy, which is where the bladder protrudes through an abdominal wall defect, this can lead to adenocarcinoma. So this is a very rare cancer, but you're only going to get it if there's really these special circumstances going on. And that concludes our module on renal and bladder malignancies.